Good afternoon. It must, I first of all would like to acknowledge the Wellcome Trust for giving me an opportunity and the Global Forum for giving me a chance to come over all the way from India to make this presentation, and Dr. Buenos for working with us through the case studies and helping us to revise them. And you must be surprised at the number of studies on diabetes and chronic ailments which are coming and almost seem to be centered in the same region, or pregnancy-related problems. It's possibly because of the more evolved state in which this work is being done, where chronic diseases are a way of life, and particularly in southern India and mostly in Kerala. Okay, so I'm going to go through this by describing the original study and then talking you through the possible ethical analysis and throwing in a couple of suggestions on the way to resolve this. There was this study on gestational diabetes mellitus, and this study was being undertaken because there is a public health sector policy for screening for gestational diabetes in the state of Kerala. So the person, my colleague, Dr. Sakina, was part of the government health system, and she decided to look at what are the patterns and factors associated with postpartum diabetes screening of women who had gestational diabetes mellitus during their most recent pregnancy, and also to document the patterns of postpartum morbidity among these women, and to also look at health providers' perspectives on what would be appropriate follow-up for the women with GDM. That was the original study. And so the study site was Malappuram, as you can see. It's somewhat in the central part of Kerala. It has a population of about 4.1 million. And it has the highest, Kerala itself as a state has the highest density of population in the whole country. And Malappuram is the district with the highest density of population within Kerala. The female work participation rate is very, very low in this district. The fertility rate is, in Kerala, is 1.6. As you would all know, this is below the replacement level for fertility for the growth in the next generation. But Malappuram is the one district where it has the highest levels of fertility in the state of Kerala. And it is in this district that the blood sugar levels, 14% of women aged 18 and above reported blood sugar levels of 140 mg per dl or more. So the original study was a mixed methods approach, used both quantitative and qualitative approaches. The study was to include 200 married women. The reason why we say married women is because in the Indian context, there is no imagination of pregnancy without marriage. So women are married and then they get pregnant and they are diagnosed with GDM. And this is a state which has 100% almost institutional deliveries. So we could recruit women through hospital-based records, look at the potential for follow-up in 6 weeks following the birth was what was being looked at. So 4 hospitals, 3 private and 1 public, which accounted for a significant proportion of births, especially referral births, which has these complications in the district where the sites of recruitment. And the study had both a structured interview schedule and in-depth interviews for the provider component. So what is the problem? The conundrum which comes because of marriage, the law, and the demographics in Malappuram. Marriages are near universal, with 84% of the women and 70% of the men 15 years and above or more, or almost married, divorced, or they have been married at least once. The legal age of marriage in India is 18 for women and 21 for men. In Malappuram district, about 2.3% and 9.4% of the girls were married by ages 18 and 21, which means about 2% of the girls are married before the legal age of marriage. So what are the problems? Persons below ages 18 are not recognized as adults under the Indian law. This is the Indian Majority Act of 1875, which is a colonial legacy and has been subsequently modified, but the age criteria has not been changed. Marriages before age 18, it's not legal. But after marriage, women in India and Malappuram tend to move to their marital homes, and parents are generally in the old home, the place where they got married from. And there is no notion of an emancipated minor under the law. And persons below the age 18 need to provide assent prior to participating in research. And this assent is now supposed to be backed up with consent from the legal guardian. And the legal guardians are the parents of the young adolescent. And in the absence of the parents, or if the person doesn't have parents or any other person to act as legal guardian, the government comes as a legal guardian, and the collector of the district or the administrative head of the district becomes a legal guardian of the woman. Sorry. So, regulatory requirements. Who would then be the legal guardian of that married woman who is below the majority age and is living in her marital home? And from whom would we obtain consent for such a woman? Because after marriage, as has been pointed out to you, the young married woman moves to the place where her in-laws are living. So for researchers, asking the woman to participate and attempt to obtain consent from parents, usually the parents can be, if they are in that district, about 90 kilometers. That's the distance has to be covered to locate parents, maximum distance. Sometimes they could be in the same village, but the villages in Kerala are pretty large, and a village can have up to 12,000 population. The in-laws, if you try to go and find the parents, there would be this problem that in the society, the in-laws have power, more cultural and socio-cultural power, because it's the woman who comes into their home, and it would be seen as disrespecting the in-laws if you go seeking parental consent. The parents may not be available easily in the neighborhood. The second option is to treat the parents-in-law as in loco parentis and seek consent from them. The marriage itself is not legal, so it would be seen as legitimizing something that is illegal. The parents-in-law may not actually have the best interests of the married adolescent, as culturally they are seen as having control over the woman's movement and other actions. Now, the third option is asking the husband to consent. Now, he himself may not be an adult. He might be a migrant because there's a lot of migration in that region, and he may not be physically available. And it actually undermines the woman's autonomy to decide for herself. And in sexual and reproductive health issues, the partner's position at times may be in conflict with that of the woman herself. So what the researcher decided to do, because it was a master's dissertation, there was very limited time, attempting consent from parents, etc., would have been too difficult. And so the ethics committees in general would be very reluctant to allow no consent from parents or treat it as consent waiver or any of those things. So the researcher decided to exclude married women below age 18. What are the biases? Gestational GDM is associated with higher maternal age. Most of the studies that have been done on GDM do not have a large number of women below age 18 at all. So the reported age patterns of GDM could be affected by this artifact of having a lesser number of women in the adolescent ages. All women who get pregnant are at risk of GDM. If women are likely to get pregnant, then the risk of GDM also exists for them. And they should be equally included in studies on GDM. And not including them could actually affect the estimated age pattern of GDM. And it would yield biased estimates and the screening risks, because if they are very young women, they're more likely to not to be screened than be screened. So what are the risks? Adolescent women below the age 18, they're already vulnerable because of the age, the power relations in the household, in the family, is further enhanced because of the marital status. Her own decision will not be respected in the affinal home. Research on potential screening program would actually benefit from having these women. To exclude them from research due to administrative and logical inconveniences is unethical. You have this young adolescent girl, given the gender power relations, she's now married before she's supposed to be legally married. She's now pregnant, and she may be at risk of GDM. This is the problem. What we thought of was two suggestions. One is to recognize a married adolescent as an emancipated minor and seek her consent alone. She could as well be and this is true in Malappuram, she could as well be the most educated person in the household. And she might be capable of making decisions for herself and her child. And also the other option was to ask within that household where she resides, who could be the person who has her well-being at heart, and seek consent from that person. The advantage of doing this is that should she need support for transport or further care for herself, there would be support within the household. The problem with implementation for the first one is it needs change in laws, as it's a legal position. Laws are difficult to change in any context. You can see that the Indian Majority Act dates to 1875. And suggestion 2, ask her who within the household where she resides. For this suggestion, the problem is that regulatory creep that is emerging in the Indian regulatory system due to clinical trials has made ethics committees very, very wary of giving any leeway to researchers. This affects all researchers if they make any allowance for one study, because precedent is set up, as has been pointed out. And in the Indian setup, the ethics committee is becoming, instead of a watchdog for human subjects' well-being, it's becoming an extension of the regulator's arm. And therefore, there is a need to develop some kind of guidance that evolves either locally or globally to address this issue.
So we're going to move in a minute to an ethics discussion taking into consideration both of these case studies together. But before that, I'd like to offer the same courtesy. Are there any questions of clarification just with regards to the details of this particular study? Do you want to take?
Hi, my name is Ignacio Mastroleo from Buenos Aires, Flaxo. My question of clarification is that if I understood correctly, these women, at least potentially, are economic dependent on their families, because you mentioned 7.4 of them are actually in the workforce or something, so they have an extra layer of vulnerability. I would like to clarify that, if it's that.
Yes, it is. They do. They do have an extra layer of vulnerability, but you have to also understand that it's more or less common in that region where women's workforce participation is very low.
Yeah, I understand, and that reminds me what happened like in the end of the 19th century in UK, for instance, but it was a problem at that time, and now here.